All right. Hello, everyone. Thank you for tuning in today. This is the fourth webinar in the Dravet Syndrome Foundation's Listen Plus Learn professional education series. We'd first like to thank our educational sponsors who made this series possible, which includes Greenwich Biosciences, Neurelis, Zogenix, Encoded Therapeutics, and Stoke Therapeutics. We'd also like to thank the American Epilepsy Society for their partnership with DSF to provide CME accreditation for this series. We'll be sending emails following the session today with instructions for claiming credit. Lastly, all registrants should have received a link to a survey to assess the baseline knowledge of Dravet syndrome among professionals prior to accessing this webinar series. Please keep an eye out for a follow-up survey after the live series completes on November 16th, and consider taking a moment to fill this survey out, even if you were unable to complete the pre-knowledge survey. Today, feel free to drop questions in the chat at any time or hold them to the end to ask yourself over video or audio at the end of the talk. With that, I'm going to introduce Dr. Kelly Knupp. She completed her medical training at the University of New Mexico and completed subsequent residencies in pediatrics and pediatric neurology at Columbia University, at the Children's Hospital of New York, and the Neurologic Institute of New York. She additionally completed a fellowship in clinical neurophysiology at the Neurologic Institute of New York at Columbia Presbyterian Hospital. She is currently an attending physician at Children's Hospital Colorado in pediatric neurology and neurophysiology. She's an assistant professor of pediatrics and neurology at the University of Colorado School of Medicine, and she's director of the Dravet program at Children's Hospital Colorado, as well as a member of the medical advisory board for DSF. Her interests include Dravet syndrome, infantile spasms, and early pediatric encephalopathies. DSF is so pleased to have Dr. Knupp here today to share expertise on how to navigate the transition of care from pediatric to adult providers. Thank you so much, Dr. Knupp.
Well, thank you for that kind introduction, and thanks for inviting me to speak about this topic. I feel like, these Zoom talks are still like a little new, so hopefully I don't have any IT issues as we sort through this, but don't hesitate to, if there's an issue, say something in the chat and point it out to me, because it's hard for me to see everybody and see the slides at the same time. So I'm talking to you about transitioning from pediatric to adult care. And let's see, my slides are not advancing. Now I think I'm good. And I do have disclosures. I do research, and I provide some consulting for a number of different pharmaceutical companies, in part because they have products that may potentially help people with Dravet syndrome. And I know some about Dravet syndrome, so people reach out to me. I don't think that this impacts much of what I'm going to talk to you about today, but wanted to share those disclosures. Probably the most important disclosure that isn't listed on the slide is that I am not very successful in transitioning my patients. And so I'm going to talk about this, and but I think this is something that as providers, many of us struggle with, and I'm right there with you. So while I've been working on this for a while, I haven't been terribly successful in transitioning patients yet. Just some learning objectives. We'll talk briefly about the difference between transition and transfer. I think that's important to keep in mind. I am going to point out some resources that we have found to support transition of care, and then discuss some transition ideas for this particular population. Really, just to be upfront, the reason I've been interested in this project is, as I mentioned, I actually haven't been successful in transitioning my patients, and wanted to come up with a good, reliable, and safe way to think about transitioning and transferring my patients into an adult model of care. And so we've developed a group of people who have been working on this for a while. We've been a little bit derailed by the pandemic. And so really, I'm just going to share sort of the process that we've gone through so far, and how I hope that this will be successful in the future. So that's really sort of the flow and the focus of my talk today. And I hope that it will generate some conversation for us to have at the end of this discussion, because I'd love to hear ideas that other people have used that maybe are successful, because I think many of us struggle with how to do this. And so just, I want to differentiate a little bit between transition and transfer. And the reality is we actually have to do both with our patients, but sometimes we just do one and not the other. So transition is actually preparing to move from child-centered to an adult-oriented healthcare system. And so this is really preparing us as providers, preparing the receiving provider, and most importantly, preparing the family to be able to transition. Transfer is the actual change of care from providers, from pediatric provider to an adult provider. And the truth is, transfer has been going on for a long time. For many, many years, we have said it's time for you to transfer your care, and we say this is the last time I'm going to see you. And that is sort of the important step that needs to happen through this process. But transition actually happens long before that, and probably should happen for a time period after the actual transfer of care. And so we really need to be doing both of these processes. So, here in Colorado, I have a large number of Dravet patients, and every year it seems like they get a little older, which I shouldn't be surprised by. And, eventually it may not be appropriate for them to be seen in a pediatric children's hospital. This has been a particular challenge for me. I have patients who are in their 30s, because I continue to hold on to them. And I think they like me, and they continue to hold on to me too. And honestly, I would be happy to provide care across the lifespan, but it creates a bunch of issues within the hospital. We have pediatric nurse practitioners who can't do refills for patients after the age of 21. Our psychiatric care providers are very challenged to provide care for patients actually beyond the age of 19. So if a patient gets admitted to the hospital, it may be hard for a nurse practitioner to see them for other types of care, and hard to access psychiatric care. And the reality is there's a shortage of pediatric neurologists, and this is probably going to get worse before it gets better. And so at some point, we probably do need to think about transitioning our patients. But it's a really hard thing to do. And so my approach to this was to gather a group of stakeholders. I recognized that this was going to be an increasing issue. The excuse that I have been using to follow my patients is that many of them were on medications that required an IND, and I was the only IND holder. Therefore, they had to stay under my care, and that was changing as things were getting FDA approval. And so at some point, I know that my institution is going to tell me that I can't see people in their 30s and 40s anymore. And so I gathered a group of stakeholders together, a number of parents from our area. And my goal really was just to address my regional transition and transfer issues. So I had one of our adult neurologists, Christine Baca, partnered with me. And we actually pulled in one of our special care pediatricians, and who cares for a number of our patients, who also has to transition services at some point for these patients. And we also had a med peds provider who actually is very unique to us here in Colorado, but she actually sees patients both at the Children's Hospital and across the street at University Hospital. And we just started brainstorming challenges, started talking about, what does transition feel like, look like from all of these different perspectives, and what are the challenges that we have. We started reviewing the resources that were available to us for transition. We actually reworked some of those resources. Christine and I shadowed between the adult and the pediatric clinics, and also shadowed some multidisciplinary clinics. And some of our parent participants shadowed in that multidisciplinary clinic as well. And we also were working on planning a conference. One of the things that we identified as a challenge is that there's some, particularly for Dravet syndrome, there isn't really a lot of knowledge in adult neurologists about how to care for patients with Dravet syndrome and what to expect, or using some of their unique medications. And so we thought that it would be very helpful to plan a conference to start providing some education to our adult neurology colleagues and some of the providers surrounding that. Unfortunately, we were supposed to do that in April, and the pandemic hit. And so we are still working on trying to figure out how to redo that and changing the format of that, and something that we'll be moving forward with early on in 2021. Through this discussion, we actually identified so many steps that actually need to happen through this transition and transfer process. And Christine Beck is a very visual person and put this together. And I really like how she has sort of spelled out the experiences that people talked about. From a patient health standpoint, you get your initial diagnosis of Dravet syndrome, but you could really apply this to any pediatric onset complex epilepsy. There's ups and downs through that care, and you need ongoing diagnosis and treatment. And we have some comorbidities that go along in there, some of which may get worse and get better throughout the lifespan. And then there may be some new medical problems that start to happen, particularly as we enter into adulthood and maybe have some adult diagnoses that we're not so used to in the pediatric population. The healthcare system is largely what we're talking about when we talk about transition and transfer. Where we have pediatric care, and then we have this murky area where there should be some, the transfer happens, but we actually need transition preparation before that, and then move on with adult integration. But from a parent life perspective, there's some steps that happen here too, and all of these are happening kind of along the same lines, and we have to keep these in mind as we think about these processes. We have parents who initially are searching for a diagnosis, and hopefully, particularly for Dravet syndrome, are getting the appropriate diagnosis early. But then I think there's still some searching and trying to figure out best treatment, which is ongoing. But I think particularly early on, it's hard to know how much to compromise with side effects of medications versus seizure control and those kinds of things. I think many parents then settle into, after searching and finding a diagnosis, a time period of education about what that disease process looks like in general, and particularly related to their child and their home life. And then many families move on to an advocacy phase, and the whole time trying to find family, work, and balance, and then coping with aging. So a number of things that happen throughout the parent life. From a legal standpoint, there's not usually a whole lot going on until we get into sort of the mid to late teenage years. But some of this starts a little earlier than we think, usually around 13 or 14. From a medical record standpoint, in a typical child, we cut off parental access to a lot of medical records. One of the things that we use a lot in our electronic medical record is something called MyChart, which is a way to send messages back and forth. And at some point around 13 or 14, parents aren't always able to do that anymore. And so we have to get specialized access for parents of a child who can't make those decisions to continue to have access, which gets even trickier when we turn 18. We also have to go through guardianship and figure out all the legal preparation that goes into that. Otherwise, it gets to be quite challenging when you go to pick up refills at the pharmacy and sign forms and things like that. So all of this is happening at the same time. For many of our patients, they often have a combination of private insurance and Medicaid, and may have waivers here, but all of those programs change a little bit as you between 18 and 19. And there's always the fear that depending on the insurance at age 26, the child may not be carried on their parents' and private insurance anymore. And so that's something else that we have to keep in mind through this process. And then there's education. Children often start off in early intervention, and then require an individualized education plan throughout the school years, trying to figure out, are they mainstreamed or are they in a specialized classroom? How do they get their educational needs met? There's this murky period where I feel that Every district in Colorado manages this a little bit different. And I feel even within a district, a specific high school may manage this different, where some children graduate at age 18 and transition into adult care, and other children are maintained in the school system until age 21. But how the schools manage that and what the services are like, and how much is available, can be very tricky. We do occasionally have some children who actually are able to go on and do some type of higher education. But I find in particular with Dravet syndrome, many of my patients are not able to do higher education, but they're really social kids, and they really need contact with their peers. And so we end up families end up looking for adult day programs and things like that to serve those needs. And so there's a lot that's happening. And, what I think is really notable when we look at this is I feel like often from birth until 14 or 15, it's kind of a period of stability. And then you see there's sort of absolute chaos that's happening through all of these different domains that need to change until we end up to a period of stability as we approach adulthood. And so this is a lot of moving parts to go to happen, and a lot of things that parents need to coordinate. We, in our group, we actually reached out to identify some resources that are available. And this is actually from the American Epilepsy Society. And they have a nice grid to talk about things that need to happen when we transition from pediatric epilepsy to an adult model of care. And I realize that this is kind of hard to read. I really just put this up here so that people were aware that this was out and available. But I will say, as we looked at this, some of this doesn't always make sense. And a lot of these transition things that are available are seem to mostly apply to children who can actually participate in their care. This particular one from AES is a little bit better and does talk about the child with significant developmental disability, so it's a little bit more appropriate. But I think the most important thing is that it really starts from 10 to 13, that we should be talking about a transition plan and realistic plans for adult life and what those plans will look like as we transition. So it's not suddenly a surprise as we approach age 21 that we suddenly have this transition thing that needs to happen. And as you can recall from the prior slide, 10 to 13 is probably the right time to start talking about this, because a lot of these things that need to happen really start happening around 14, 15, 16, some of these changes that need to happen. One of the things that I particularly liked about this is that it does emphasize the need to verify the epilepsy diagnosis. Particularly with genetic testing, I think we do this more frequently. But I know that there was a tendency that we would just have some general labels on children without a specific etiology for their diagnosis. And I think it's really important as we think about transitioning and transferring patients into an adult model of care, that we've done everything that we can to help our adult colleagues to figure out what that underlying etiology is. Because while they are rapidly learning about genetic testing and looking for specific etiologies, for pediatric epilepsy, that's something that we're the experts in, and we really need to make sure that we've done our job before we think about transferring our patient into that adult model of care. We also found some resources at the Child Neurology Foundation, and this is something that has been used in our clinic. As we looked at this, we did not think that this really applied to our patients. And so we actually worked to rewrite this. We did agree with some of the concepts behind it, but just the way that it was worded really worked much better for a child and family where the child is able to participate in the care and the transition of care. And we did not think that that was appropriate for our population. So we were able to take this and rework it. And so this is a little bit bigger so that you can see it. But again, we really have this idea that we really need to start talking about this at 12 to 14 years of age with an open discussion and preparing this. And usually when I start this discussion with families, I'm like, I want to mention this to you. We're not thinking about doing this now. I just want to make sure it's in the back of your mind that at some point you will have to transition to an adult model of care, and we want to make sure that you're ready to do that. And making sure that we talk about potential barriers for the individual and the family, identifying goals and specific transition milestones for their upcoming years. And in discussing this, sometimes it really has come out, that it might be better, instead of having, the care in the Denver area, which is where the Children's Hospital is located, and we have families who come to us from an 8-state area, that it may be that we really need to identify a provider closer to home, so that the family doesn't have to travel as much, particularly as the family is aging, or maybe they've already identified, who an alternative caregiver may be as the child transitions into adulthood. It would be easier for that caregiver to have closer care. And so it really is helpful to start thinking about these things well ahead of time. This also helps us start this conversation about guardianship. At age 18, a youth legally becomes an adult, and parents lose the legal right to make decisions for the child. I have experienced this in my own life. My oldest is 20 years old, and he's a very bright, typical young man, but it was a little shocking to me when suddenly he could make decisions on his own and sign for pretty much anything on his own, and didn't need our permission anymore. And so even in that situation where this is something that's expected as part of normal development, it's a little shocking. And we've definitely seen instances with families when, as soon as the child turns 18, suddenly the parents can't order the refill at the pharmacy. The pharmacy, who may even know the family quite well, is demanding to speak to the child, who may not have enough language to order that prescription. And these things can become difficult. And so we want to make sure that people are thinking about this ahead of time, so that it's not so much of a surprise. And then we list the things that we are willing to help families with, that we want to help them choose an adult neurologist and facilitate conversation between ourselves and that adult neurologist, ensuring that there's a plan for medications in the emergency department, particularly during this transition period, when sometimes it's a little unclear who they should call for help. Guiding families through the process of obtaining medical records and providing summary documents. So at our institution, we actually draft a transition letter when we know that somebody is going to see their adult neurologist for the first time. So that they know, what the history has been, what my biggest concerns are, what my next steps were, and what the family and I had talked about, so that provider has that information. Particularly for some of our epilepsy patients, the stories that families have to tell sometimes can come across as a little unbelievable. And so it's very helpful to have that transition letter to say, yep, that's actually how it happened. And that we really did have that, 4-hour episode of status that happened after somebody gave a wrong medication, just to reinforce that. One of the things I talk to families about is that it's very reasonable to go visit the adult neurologist first and then come back and see me. This is developing a new relationship, and so to view it a little bit like dating, and taking a couple of first steps to dip your toe in before you're in all the way. And sometimes there are adult neurologists where it just isn't the right match for the family. And it's really important to recognize that before the full transition of care has happened. We are able to, as best we can, to support insurance coverage barriers. Sometimes the choice of an adult neurologist really does come down to insurance issues as well. And we will do everything we can to help support that. And also making sure that there are medication refills throughout this time period. Helping to choose an adult neurologist, I think, is one of the biggest challenges. And, as we spoke in our group, for me, I get very attached to my patients, and it's hard for me to say goodbye to them, which probably hasn't really helped my transition technique very much. But I think families feel that same way. Over the years, we've developed a relationship where both of us know what to expect from each other. And suddenly you have to establish a new relationship with a new person. And that can be really hard. And it is important to find the right adult neurologists. Adult neurologists sometimes have gone into adult neurology because they don't like dealing with the family dynamics the way we do in pediatrics. So it's really important to find a provider who feels comfortable providing care to the entire family, because this is not a child who's going to go in and see the adult neurologist all by themselves. And the vast majority of adult neurologists are very happy to do this and enjoy this type of relationship. But it's important to make sure that that's a relationship that's going to work for everybody. That's this decision of, is it reasonable to travel? If you're coming to me from 1 or 2 states away, is there an adult neurologist more locally who can provide the same care as our adult neurologists? There are just a lot more adult neurologists than there are pediatric neurologists. And just to kind of put some numbers to that, during my training, we had 14 adult neurologists in the program and 2 pediatric neurologists that were training in a single year. And so that's a pretty similar ratio of what we see. So there really are a whole lot more adult neurologists out there. Insurance can be an issue. The provider has to be willing to take Medicaid, and sometimes primary insurance may dictate options, particularly if it's an HMO type of insurance. So those are things that we have to keep in mind as well. And then we have to keep in mind experience. Has the provider cared for adults with developmental and epileptic encephalopathies? Have they cared for adults with Dravet syndrome, or do they know whether they've cared for adults with Dravet syndrome? And there are several new medications in the pediatric world that are not available, not readily available in the adult world. And so this may be a barrier. And in particular for my patients, this is the barrier that we've been facing. A huge number of my patients are on a number of medicines that are relatively unique to kids with Dravet syndrome, including stiripentol, fenfluramine, and Epidiolex. Epidiolex, I think, is used a little bit more broadly, but stiripentol and fenfluramine until recently required an IND or trial use. And so I was the only registered prescriber for stiripentol for a while. And so having those patients go to an adult provider means that they wouldn't be able to get their medicine, or they still had to keep coming to me to get their medication. And this knowledge base has really been developed within the pediatric world. And so we need to make sure that our adult colleagues are starting to become familiar with the quirkiness of these medications. So we did have some specific concerns that we brought up, and I'm going to go through each one of these and sort of how we have proposed to address these. One of our big issues is, how do we facilitate communication between pediatric and adult neurology? There are sort of 2 time periods where we really felt that that communication was going to be important. The first is pretty obvious, which is at the time of transfer. So, we want to make sure that when this complex patient lands in the adult neurologist office, that the adult neurologist has all the information that they want and need at their fingertips so that they can best learn this new patient and how to take care of them. But it was very quickly identified that many adult neurologists don't feel comfortable taking care of patients with complex pediatric onset epilepsy, and that they may actually need some ongoing support during the time of the care with their patient. And this really does impact that relationship between the provider and the family as well. I mean, I will freely acknowledge that my patients' parents know more about Dravet syndrome than I do. They live and breathe this every day, all the time, and they know that. But that's something that I have become very comfortable with. For an adult neurologist, that may take time to learn that, and their degree of comfort is probably very different than mine. Many families with Dravet syndrome have run into many healthcare providers who don't even know how to say Dravet syndrome properly. So first you have to get past Dravet syndrome into Dravet syndrome, and then learn what that is and some of the quirky things that are associated with it. And that also can make a family feel really uncomfortable, that they're not really sure who has the knowledge to take care of their child. And so having that ongoing communication after the patient has transferred is probably really important, so that they can reach back to people who can provide some educational and academic support to them. And one of the other questions that came up is, how do we ensure that research is available to adult patients? As time has gone on, we're seeing more and more research available for children with Dravet syndrome, and some of those studies have extended into the adult population. For me, those adults are still receiving care at the children's hospital, so we're able to provide those research opportunities to them. But how do we ensure that as they transition into an adult model of care, that that research is still available to them? And then one of the other big challenges is how do we transfer care for all of the subspecialties involved at the same time? I mean, it seems to me it's pretty overwhelming to see 12 new providers in 12 subspecialties all within the same year. But it also can get really complicated for care if half of it's at a children's hospital and the other half is at the adult hospital. If you need to be admitted for pneumonia and you've transferred your primary care, but you haven't transferred your neurologist, which hospital do you go to for that admission? And so this is a challenge that we definitely need to work to address. And how do we assist families to establish trust in the new provider? Trust is something that builds up over time. And, I fully recognize just because I say I like somebody doesn't mean that the family is going to like them. And so that's something that is really important in this transition time. Um, so I think I've already mentioned, so when we think about communication between providers, we have a transfer letter that we write, which I think is really helpful, but it is, it ends up being a 12 to 13 page letter that summarizes all of this information. One of the ideas that we think would be really helpful is doing a combined visit where the family sees both providers in the same visit. And this allows for communication about both long-term and short-term issues and involves the family in that communication as well. And I think this goes a long way in, the adult provider feeling supported as they're starting to take over the care of this patient, but also in developing that trust in the adult provider that, the family knows that they did actually receive the information that they needed and that they've made that connection and that hopefully they'll feel comfortable reaching out to me if they run into trouble in the future. This does have some billing issues that we've been trying to work our way through. We think we've come up with a couple of ideas of how to do this. Where one person bills for reviewing records while the other person bills for actually seeing the patient. And then when they fully transition to their adult provider, they're able to add that extra billing on to account for that combined visit that happened. But we are still working with our billing specialists to finalize that and see how that works. Communication between providers long-term. So this is something that's challenging. And, we recognize that we don't have an adult neurologist who specializes in Dravet syndrome the way we do in pediatric neurology. And, so one of our thoughts has been to develop a Dravet clinic that will have both adult and pediatric providers. And I think that this actually creates a situation where that adult epileptologist is becoming a specialist and actually is able to speak to the pediatric provider, and both of them can sort of collaborate together and continue to learn and share their knowledge about Dravet syndrome. Our other thought is to have monthly or bi-monthly meetings to discuss care of adults with developmental and epileptic encephalopathies, and with a combination of a didactic session and a discussion session, allowing, and this is something that we would sort of view as happening locally within Colorado, so that people really get to know each other and can start bringing issues, questions, concerns to that discussion as they care for these patients, so that we can have that exchange of knowledge occurring. How do we make research available to adults? Our campus actually is very interested in developing research across the lifespan. Like many other academic institutions, we have a freestanding children's hospital right next to a university hospital. And, this is, a great situation where we can easily develop research in lots of different disease processes across the lifespan, because it turns out, particularly for genetic diseases, but true of many healthcare issues, they don't go away when you turn 21. That just isn't the way that the world works. And there are a lot of logistics that need to happen for this to occur. Our particular institution, which is again not so different from other institutions, is really 3 different business entities. So the Children's Hospital is its own nonprofit business entity that has research interests. I am actually university faculty and I work at the University of Colorado, and the university obviously has its own research interests, and the university hospital is also its own entity. And so, a lot of these challenges really have to do with contracting, finances, to bring these three entities together. We are very fortunate because we have an initiative right now at our institution that is trying to figure out how to do this, developing something that they're calling the Child Health Research Enterprise. But one of those goals is to really streamline some research across the lifespan at our institution. And it's possible that if we develop this Dravet clinic, that actually might be a site of recruitment, and that may be a place where we can see adult and pediatric patients on, every year, every 2 years, so that people know that they have that hub to come back to hear about what's happening in research across the lifespan, so that we can continue to learn more about Dravet syndrome in the adult population. The transfer of care for all providers. This is something that I think definitely needs a local solution. It is difficult enough to transfer neurologic care. To transfer all of these other cares, I think really depends on the local milieu. And so I'll talk a little bit about what this will look like, what we think this will look like for us, but I really think that this is something that really requires a local task force to do this. And it really is not something that's unique to neurology. It's something that is needed for all children who have chronic medical needs, how to do this. For us, the university hospital is often the location for this care. So adults with complex care often get cared for at our university hospital. And so we actually have a unique clinic called the Special Care Clinic, which is a primary pediatric clinic, which is designed for children with chronic medical needs. And is used as a primary care provider. Not all of my patients use that clinic, but many of them do. But they have a med peds provider who actually sees patients in both settings. And one of the things that she is willing to do is to start seeing patients who are in that older teenage years, 18, 19, 20, start seeing them in the pediatric hospital and then helping them transition all of their complex care over to university hospital. And so that's something that's very unique to us, but very powerful. And we've been starting to use that. And I actually do have a handful of patients that have just started using her as their primary care provider, which will allow us to move forward with this transfer of all of the specialty care in the future. Establishing trust in new providers. This is the hardest part because, I think we all know this from our relationships. Just because I like somebody doesn't mean that somebody else likes them. We all perceive everybody a little bit differently. And it really is important that we give this some time. This is going to be a new provider to the family. And I would not expect them to trust the new provider after that first visit. I really think that this is something that takes time to develop, and we need to make sure that we do that. I think our idea of doing combined visits contributes to developing that trust. I think inviting more and more adult neurologists into the conversation of Dravet syndrome will go a long way to help develop that trust as well, because seeing a provider who knows a little something about Dravet syndrome will really start things off right. And I think that we do need to continue to convince our adult neurologists that they need to learn about some of the uniqueness about pediatric onset complex epilepsy, particularly as we're seeing more and more genetic disorders. I think that my adult colleagues are very, very good at managing seizures. I think that their knowledge about genetic disorders is growing, but probably doesn't grow quite as quickly as ours has in pediatric epilepsy, because they haven't had the genetic testing available to them for their patient population that we have had in our patient population. To address some of these needs, we've also talked about conferences, and I mentioned that we had planned a conference to really start providing this childhood information about childhood onset complex epilepsy to our adult neurology colleagues. And some of the things we really wanted to highlight in this first conference was talking about unique meds to Dravet syndrome and what Dravet looks like in the adult population. Like everything else for everybody in the last 9 months, Our plans kind of got turned upside down related to the pandemic. And so we are rethinking this, but one of the goals that we had really hoped would come out of this were ongoing open discussions about how to support our adult neurology colleagues with patients who've transitioned. And so we are reworking this. And we'll probably do this instead of as a single half-day conference, do this as a series of Zoom conferences here locally in Colorado to meet these needs. And we're hoping to initiate that in the beginning of 2021. And then we've talked a lot about developing a Dravet clinic. This is a clinic that would provide some multidisciplinary care. Our goal is to provide care across the lifespan. We think that this could also serve as a diagnostic clinic for children who are relatively new to a diagnosis or have a question of a diagnosis of Dravet syndrome. I think one of the questions is, who else do we get to participate? Who is it that a child with Dravet syndrome needs to see on an annual or, every other year basis? And our list is that has been developed so far is rehab, nutrition, GI, our special care provider, so that they can help wrap this up in a more holistic approach, and a behavioral therapist. And our goal is to see patients every 1 to 2 years. And so this is something that we are working towards as well. This has also been sidelined a little bit with the pandemic. We are still not here in Colorado fully seeing all of our patients in person. So adding a multidisciplinary clinic and trying to maintain social distancing and getting all of these providers into a single clinic is not an appropriate thing to do right now, but we are working on some of these plans behind the scenes so that hopefully we can have this in place in the next 12 to 18 months. The pandemic has provided some opportunities, though, and Christine Baca, who has been accepting patients in transition, has actually found that telehealth has been quite helpful with this, and has raised the question of whether we should be using this more. And I think this is worthy of discussion, and I'd love to hear if somebody else has had some experience with this. It actually, in a telehealth visit, it actually does allow for a little bit more focus on the history and a little bit less on the exam, because the exam is somewhat limited by telehealth. And really I think for both the family and the adult neurologist, one of the more important things at that initial visit is really understanding the history and what has happened before and what needs to happen next. And so I think that allows this to happen. I think this visit also occurs in a setting that everyone is more comfortable with. One of the biggest things that Christine and I have talked about as we've gone back and forth between our two institutions is that, a children's hospital is bright and cheery, and there are therapy dogs walking around, and they're happy things for kids. And, and our nurses are, very kid friendly and family friendly. And it's just kind of a feel good place. When I go to the adult hospital, it smells like a hospital. People are a little grumpy and irritated. The colors are a little bit more muted. Her staff is amazing. They're phenomenal, but they're not the same happy-go-lucky crowd that we get in pediatrics. And because it's not always appropriate to have that crowd for all patients. And so that setting is really very different. And so, just getting into the adult hospital can be a really stark difference from what families are used to. And so I think having this first visit as a telehealth visit allows that stark difference to kind of be postponed to another visit, which I think actually may be a helpful thing. So I think definitely some benefits to think about in this situation. So what next? I already mentioned that we're reworking our conference to provide education to adult neurologists in Colorado. We have a multidisciplinary clinic plan that is on hold, but we will start revisiting this again in that says 2020, but I meant 2021. So a lot of things that we are putting off right now, but we'll be revisiting in January to move forward with this. So I have to admit, as of yet, I have not transferred any of my adult patients, but many patients have now transitioned onto commercial product for fenfluramine. And I think this is something that I really do need to start focusing on doing in the next 6 months or so. But want to make sure that families are prepared to do this and that we have an adult neurologist who's ready to receive them. So this is really an unfinished project. I would love to hear how other providers are addressing this and how they are meeting some of these challenges, and if they have some additional challenges that I didn't mention here. But before that, I just want to many thanks to our team. Christine Baca is our adult neurologist. Eleanor Floyd is our med peds person. Courtney Santucci is from the special care clinic. Jennifer DeSabato is one of our nurse practitioners who actually specializes in transition, and it has been so helpful to have her overall perspective in transition and how we need to tweak it for this patient population. Craig is one of our nurses, and our most valuable input are the parents who have really put their time into this and have been so open in sharing their feelings with us, and have helped guided us through this process. And I think with that, I will open this up for questions. I am going to stop sharing so that we can put this in gallery view, and hopefully that will facilitate a little bit more discussion.
Yeah, if anyone has questions for Dr. Knupp or has comments on, facing similar challenges, this would be a great time to throw that out. I can ask a question that I had.
Yeah.
How do you I know you said early teens is kind of when parents start to run into the issues of not always having the most access to manage their children's care. So how early then are you discussing the sort of the discussion around all these legal issues? So not just the transition, but how do parents stay in charge of the transition, I guess?
Yeah. So I have really been trying to, and I'm a little more aware of this now that we've been going through this process, but I really try to start this discussion around 13. So sometimes I will start that discussion even earlier, particularly if I think that the family is not fully aware of the limitations of their child. That doesn't happen very often, but sometimes families will say things to me like, when my child has their family, and I'm thinking, is that really feasible? And I don't want to burst anybody's bubble and their plans. I know that it really is a process to kind of accept where your children are at and what the realistic possibilities are, but I also want to make sure that I'm not encouraging thoughts and ideas that may not be that realistic. And but generally around 13 is when we start talking about it, and I really talk about it from a couple of different perspectives. Realistic, what is your child capable of doing, and really trying to find out what kind of support does the family think that their child needs to have. And sometimes there really is a disconnect where a family will, I'll ask, like, can your child go grocery shopping on their own? And they'll say, not yet, but I think they'll be able to. And then I'll say, does your child know how to differentiate money? And they're like, oh no, like they can't count high enough, and they can't tell the difference between the coins. And that kind of comes back to, can your child really go grocery shopping if they can't manage money? How are they going to make those decisions? Making sure that the families are starting to think about a long-term plan. And, honestly, many families really are. They just don't, they don't always verbalize it with us. But I think many families are already trying to think of, what do we do when our child turns 18, when they turn 21, when other children are going off to college or working independently, what will happen with our child? And so I think what I've discovered, many times it's much like a SUDEP discussion where the family often wants to talk about it. They just don't know how to bring it up. And so when we bring it up, it really opens that up. And so we talk pretty realistically about, making sure that that they are prepared to identify a guardian and what that process looks like and what support they may need with that. We have a family navigator who can help guide families through that process as we get closer to 18 as well.
I guess I will ask one more question if no one else has any burning questions to ask.
Have
Um,
a comment when you're done.
okay. So I think it's fantastic what Children's Hospital is trying to do, Children's Hospital Colorado, to kind of have this center of care where the transition, hopefully can be smoother. Obviously, that's not going to be ubiquitous, right? Depending on where someone is located. And so when you're looking at kids that are seeing multiple specialists, like you acknowledged is often the case in Dravet, are you starting this whole transition process earlier and kind of doing one doctor at a time, or are they trying to transition, multiple specialists all at the same time?
Yeah, so our med peds person, I think this is something that needs to be addressed locally to figure this out. Our med peds person is usually the person who is taking the lead on that. So they, the benefit of being involved with our med peds person is they really can see the child both at the Children's Hospital and at University Hospital. And so depending on the needs, they may decide to transition everything at the same time. So if your biggest need is neurology and all of your other needs are just sort of ancillary needs and you don't need to see them very often, it probably makes sense to transfer everything at one time. If it's something where the needs are much greater, then she really has been recommending doing them sort of in tandem, one at a time, so that there's sort of a group of providers that knows the child well and a group of providers that's learning the child new.
I think that makes sense.
Yeah, and she's able to then, this hasn't come as an issue for any of our other patients, as I freely admitted, I haven't transitioned any of my Dravet patients. But it hasn't, because she is able to see patients in both hospitals, they've been able to then readily determine which is the best hospital for a child to be admitted, and she's able to provide that context in both settings, which has been super helpful. So we have this challenge. Our catchment area is really, really big. And there are definitely other children's hospitals that have to manage this as well. When I practiced in New York, our catchment area seemed big to families because they had to cross over the river. But that really was relatively small compared to what my families do now. And so we actually purposely have on our group a family from the Western Slope, where it really takes them 4 or 5 hours over a couple of mountain passes to get into the Denver area for care. We have somebody who comes from down south, which is about an hour and a half away, and then somebody who's local, so that we really are getting the perspective of families who have very different needs in their transition plans.
Dr. Knupp, I have a comment and then maybe a question. I just wanted to thank you for this presentation. I think this is an aggregate of information that seems to have lived in various different places. And I love that you and Dr. Baca have kind of pulled it all together into one place. So I commend you, because I'm sure that was a lot of work and it was a wonderful presentation. I'm wondering how much of a role could other organizations like, the Epilepsy Foundation, for example, and the organization that we're with today, how much do they play a part in supporting the families with this transition, maybe identifying adult neurologists who are more likely to be accepting of transitions of care patients, et cetera? I just wonder if there's a part there that could be played as well.
Yeah, no, I think that's a really good point. And they actually have played a role in some of this work, and I'm probably remiss in not mentioning that. So I'm glad you brought that up. I mean, I think the reality for me where I live is the Epilepsy Foundation of Colorado knows virtually all of the neurologists who provide epilepsy care. And so they have been very helpful in, as we were planning our conference, making sure that we were reaching out to those adult neurologists. And, they are very good at knowing who feels comfortable, seeing complex patients and who doesn't, who is it easy to get into, because they hear this both from the provider perspective as well as the family perspective. And so I think that they're incredibly helpful in that situation. I think that DSF is, so supportive in trying to identify adult neurologists who are interested in Dravet, and providing that education to them. And so, I think, particularly as we're reaching out and trying to provide this education and academic support to our adult colleagues, I think there are huge roles for the Epilepsy Foundation and DSF to play. I think there's also a huge role in reassuring families that, yeah, this is going to feel a little awkward for a while, but hang in there. But also saying, like, if it doesn't get better, you need to find another adult neurologist, and here are some people who may be available. I think families need encouragement for both of those perspectives. And, even in our pediatric neurology practice, we have families that, most families like me, but some don't, and they need to see one of my colleagues because they can develop a better relationship there. And so, I think we also have to make sure that we're supporting families and, how uncomfortable, recognizing that this is going to be uncomfortable, but how uncomfortable do you let it remain, and empowering them to find the right person.
Great. I had a question come in through the chat asking, how is the transition statement provided to families? And are you discussing this at each visit? Is it done by you or the nurse or MA or NP?
Yeah. So ideally, it would be discussed at every visit by our nurse usually. We are actually in the process of getting children's approval for our amended statement because we took great liberties on it because we did not think the one that we had was appropriate. So we don't have the official form to be shared with our patients yet. So at this point, I'm sharing those concepts with them, but we hope shortly here to have that approved so that we can hand it out to each of our patients. And, I think it's one of those things that can be handed out, and depending on the needs of the day and how the family is feeling, I think there are times when some families may want to spend a lot of time talking about it, and sometimes when they're like, yeah, I've heard that before, or I'm not ready to hear about that, but thank you for the information. So I think it opens that up. And at least how our practice runs, if the nurse has that brief discussion with the family, I think that gives the family a little bit more time to make a decision about whether they want to have a more in-depth discussion about that topic with me.
I will just kind of add on to 2 questions ago. I just realized, this whole transition thing is really important for the foundations to be supporting. And I think, Dr. Knupp, thank you for recognizing that they are, obviously not without the help of all of these doctors like you who are so passionately dedicated to this. And it's one of our initiatives going forward right now is to try to have additional supportive documents for families to take to their providers to help with transition. So maybe they're not in a center with specialists who really understand Dravet, and who really recognize the challenge that transition is going to be. And so trying to provide those documents directly to patients to help take to their doctors and initiate the conversations themselves when they need to is something else that we're trying to, not only help make sure clinicians have those resources, but that the patients have them and their families have them too.
Yeah.
Jenny, did you say you had a comment?
Oh, yeah. I just wanted to thank you, Kelly, for bringing up, and I think it definitely, is something that people should be aware of, that you touched upon. These patients going to a children's hospital or even just a pediatric, room versus an adult room is very different. And it's like, I just kind of like giggled to myself because it's something so simple, but is probably something so overlooked.
Yeah.
And, these Dravet patients, a lot of them have, a big intellectual, disadvantage. And walking into something that's fun and lively is something that they've been doing for how many years. And then all of a sudden to go into this, somewhat cold and sterile place is when they've been in those situations, it's been in the hospital, it's been under distress, it's been, and it's something so simple, but yet like, I just wanted to bring it up again because it's, something that people can do to kind of make them, or just recognize when they're, standing back and not coming in and running to the doctor that, there's going to be a little hesitation there.
Yeah. Yeah, no, the setting, it really is. And, you know, I see adult providers, but, you know, I go to see adult providers for myself and expect that. And, you know, when Christine and I were going back and observing each other in our respective clinics, it was just such a stark difference because, you know, when I go in as a provider, I'm so used to it being a pediatric setting. And so going in as a provider instead of a patient, I was like, wow, this is like really different.
Yeah. Yeah.
All right. I don't see any other questions in the chat. Does anybody else? Oh, actually, I do see another question. Is how much time do you spend during visits discussing the transition? I think you kind of answered that in your question, that you sort of let the parents and caregivers dictate how much or how little time they want to spend on
Yeah.
it. Is that
Yeah, so, you know, my follow-up visits are generally scheduled for anywhere between 30 and 40 minutes. They keep flexing our schedules back and forth a little bit, but, you know, so probably only 5 minutes, you know, but if you do it over and over again, it allows you to add a little bit more on and allows families to have that question. Probably for some of my families, as you know, usually just before the child turns 18 and just before the child turns 21, we probably spend a little more time on it. One, just to make sure that the guardianship is, you know, moving forward the way that it should, and, you know, whether we need to identify any resources for the family. But also I find that families are pretty anxious around that time because they're fearful that we're going to kick them out of clinic. So even though I'm well aware that my family stay pretty connected on social media, there's still a lot of anxiety around those time periods.
right? Well, thank you so much, Dr. Knupp, for spending your time here today to talk about this really important issue. I want to thank everybody else for attending today. I do just want to quickly let everyone know that as of October 1st, there are new ICD-10 codes for Dravet syndrome. So this has just been another really important step in clinicians being able to code correctly and hopefully providing better quality of care, less insurance denials, and hopefully also helping us to better understand the morbidity and mortality of Dravet syndrome by using a very specific code to Dravet syndrome. And so just wanting to make sure practitioners know that these are now available, and we expect they're in most systems already now, but certainly by the new year, everyone should be updated to have these. Again, I'll be sending an email out to anyone who needs to claim CME credit after today. So be looking for that, as well as the follow-up knowledge survey surrounding Dravet syndrome in general that will go out later in November. And so thank you, Dr. Knupp, for being here today. Thank you for everyone who attended. We hope to see you at our upcoming remaining sessions in this series. Thank you.
Great. Thanks for inviting me.
Thanks.